The following podcast is part of a certified educational activity titled Seeing Beyond the Numbers in Type 2 Diabetes, Empowering Patients for Optimal Weight and Glycemic Management. Access the entire activity and complete the post-test at peerview.com/MJX860. Downloadable slides and practice aids are also available.
Welcome to this Seeing Beyond Numbers, Empowering Patients in Weight and Glycemic Management for Type 2 Diabetes, a PeerView live event. I'm really delighted to have you both here and joining us online. My name's Professor Melanie Davies, and I'm a Professor of Diabetes Medicine from Leicester in the UK. And I'm really delighted to be joined today by Professor Takashi Kadawaki, who's the president of Toranomon Hospital in Tokyo, Japan, and also all the way from Stuttgart in Germany, Professor Monica Kellerer. Welcome both. So what are the goals today, really? And it's really to think about strategies, and we're going to go through some cases to illustrate this, but really to look how globally in different healthcare systems, different parts of the world, strategies for overcoming barriers to both weight management and glycemic control in people living with type 2 diabetes. And we hope that this will augment your ability to engage with patients and other healthcare professionals to manage type 2. And we hope also to provide you with guidance on incorporating shared decision-making into comprehensive care plans. So I'm just going to start with a few opening remarks before we move into our sort of team-based discussion. And this is, I think, the most important bit of the most important figure in the ADA-ESD consensus report, because it puts the person living with type 2 diabetes right front and center of everything that we do as healthcare professionals. So ultimately, we want to help people living with diabetes, many of whom are overweight or obese, to reduce the burden of complications and to optimize their quality of life. We all want individually to optimize our quality of life, and that's no different for our patients. And in the ADA-ESD consensus report, this in the 2022 update, we highlighted, even though this was a consensus on the management of hyperglycemia, we realized that holistic care is really important for people living with diabetes. And so we give equal focus to weight management, glycemic management, cardiovascular risk factors, and also organ protection. And we now have drugs which were really originally developed as glucose-lowering therapies that can offer organ protection, particularly around the heart and the kidneys, to people living with diabetes. But it's really important that we think about the principles of care, and we articulated these 13 principles, and you don't have time to look at all of them, but they include things like the importance of structured self-management in people living with diabetes. They also highlight things like language. Language matters when we speak to our patients. Our language and our words have tremendous power to be a force for positive, but also, unfortunately, can still be a very negative impact. And we still hear patients talk about very stigmatizing conversations that they've had with healthcare professionals. And for each of these pillars, there is strategies to try and address each of these. So, for example, in terms of glycemic management, we talk about often the use of combination. So metformin is still often used around the world, but we often use combination treatments, and we need treatments that provide adequate glycemic lowering efficacy for patients. And also in weight management, we talk about the advent of lots of new therapeutic options now for weight loss, but also the importance of lifestyle advice and the option of metabolic surgery. So what about weight? And increasingly, the importance of weight management in diabetes management has had much more focus because many people live with being either overweight or increasingly obese and having excess adiposity. And we know that when we look at all-cause mortality, if people live with obesity for more than 5 years, that significantly increases their risk of dying of any cause. And why is that important? We know that if you can, if patients can lose weight through a number of different therapeutic options, that if you can lose between up to 5% weight loss, that can impact blood pressure, it can impact hyperglycemia. If we lose a bit more weight, so between 5 and 10% weight loss, we can start to have a disease-modifying effect. We can start to see prevention of type 2 diabetes, impact on metabolic-associated liver disease, and impacts on lipids. At 10 to 15% weight loss, we start to see an impact on modifying cardiovascular risk and MASH. And if we can get to more than 15% weight loss, we can really start to get remission of diabetes in those with established diabetes, particularly those with lower duration disease. We can impact cardiovascular mortality and things like preserved ejection fraction heart failure. So all weight loss is good, but the greater the weight loss, the greater the spectrum of impact that it can have on patients' comorbidities. So this is a little bit of a busy slide, but what it shows you is that we now have a plethora, a huge choice of glucose-lowering therapies at our disposal. And clearly they have a spectrum of ability in lowering A1C. So this doesn't include all the options here, but you can see with SGLT2 inhibitors used on their own, we get about a half to up to 1% weight loss, but the average in this meta-analysis was around 0.5%. And you can see that the glucose lowering efficacy increases as we use the GLP-1s, and then the greater efficacy for the combinations with insulin and SU, or insulin and GLP-1s, or GLP-1s and SGLT2. But to our current knowledge, the greatest weight loss, A1C lowering efficacy is with the dual GIP GLP-1 agonist tirzepatide with a dose-dependent effect on glucose lowering. Similarly now, previously we had very few agents that offered a lowering glucose and a reduction in body weight. And we know that with many combinations of insulin that we get an increase in weight, particularly with basal-bolus insulin. But as we look at the incretin effects, the incretin agents, particularly as we move to the dual GIP GLP-1, we get very significant reductions in weight. Also, we need to look at the impact on hypoglycemia, and we see, as we know, we've known for 100 years, insulin does increase the risk of hypoglycemia. That tends to be less when we use basal rather than either mixed or basal-bolus insulin. But with the GLP-1 and SGLT2 based therapy, we have very low rates of hypoglycemia. Now, managing people with type 2 diabetes does require more than just managing A1C. We can see that from diagnosis, we can often get a good reduction in A1C, but often we don't see such great improvements in body weight and not so great improvements in blood pressure. And it really makes a difference what we do early. So we need to be looking at early aggressive intervention. Even if we just look at A1C lowering, this data from Sanjoy Paul back in 2017 showed that what you do in the first year, if you can get A1C to less than 7%, compared to those people who weren't able to achieve that, and there was about a 1% difference in A1C, 5 years down the line, in those patients who had better early control, they had a lower risk of cardiovascular events. But we always talk about therapeutic inertia and how can we try and address that? How can we? There's things we can do as clinicians using a team-based approach, creating personalized diabetes care plans, but also things that we can do with our patients, encouraging them to work with us, that they can't do it on their own, sharing difficulties with managing their diabetes, and explaining to them that this is a lifelong condition that may change over time. So I want to move now from those introductions to really talk around patients, because we're all dealing with patients in the clinic. So Professor Kadawaki, can I come to you first to introduce your patient?
Yes. I'd like to introduce Susanna, a Japanese woman aged 61 years old. Her body mass index is 31.2. His weight is 72 kilograms. Hemoglobin A1C 8.4%. Medical history: type 2 diabetes 10 years. And lacunar stroke 3 years ago affected gait. Overweight since childhood, increased at menopause. Gained 60 kilograms since stroke. The current medications are metformin, amlodipine for hypertension, aspirin, rosuvastatin for hypercholesterolemia. In addition, some additional information. Former librarian, retired after stroke. Recently moved to your area to live with her son and his family. And purpose of today's visit is annual physical and meet new doctor.
So thank you. So that's a typical patient that you may see in the clinic. Monica, can I come to you to tell us about a patient that you may see?
Sure. Thank you, Melanie. So this is Marcus. It's a German patient. He's pretty young, with the age of 43, and he is a pretty heavy guy. As you can see, his BMI 38 kilogram per square meter. His HbA1c is 7.5, so not really terrible. He has some kidney function problems. As you can see, eGFR is 55 milliliter per minute, so it's reduced, but he doesn't have microalbuminuria. So his urine albumin creatinine ratio is 24, which is still normal. Some words about his medical history. He has hypertension and type 2 diabetes since 3 years, so since his 40s. And he has been diagnosed also with MASH, so metabolic associated steatohepatitis with F2 fibrosis, which is moderate grade fibrosis. It's reversible form. And as already mentioned, he has chronic kidney disease, and since he left the army, he steadily gained weight, more or less 30 kilograms since this time. His current medication for diabetes is metformin twice a day, maximum dosage of empagliflozin of 25 milligram once a day, and for his high blood pressure, he takes ramipril together with an HCT once a day. So, and he came in, or let's say from his job, he is working right now as an automobile mechanic, and the purpose of his first visit was just a routine follow-up.
So thanks, Monica. So these are patients that we may see in our clinic. So let's go back to Susanna, and you've already gone through some of but there was some additional information.
Yeah, additional information include Susanna uses cane due to unsteady gait. Susanna would like to go to the park with her grandchildren more often, but finds walking difficult and tiring.
So it's often those day-to-day things that really impact and motivate patients. So do you want to talk to us about what the next steps might be?
Yeah. So what would be the most appropriate next step in Susanna's treatment? 1, physical rehabilitation. 2, intensify glycemic management. 3, add insulin. 4, reduce weight. 5, ask about her goals. 6, maintain current regimen. I think, there are couple of right answers, I believe, not a single one.
Do you want to just tell us about the approach to glycemic management in Susanna?
Yeah. So this ADASD consensus report recommending personal-centered glycemic management type 2 diabetes. So address key person characteristics, consider specific factors that impact change of treatment, utilize shared decision-making to create a management plan, agree on management plan, implement management plan, provide ongoing support and monitor, review and agree on a management plan. So, Susan came to this physician for the first time, okay? So the physician will start, kind of the processes that I have been, explaining. But at this moment, clinical consideration for Susanna include the following. First of all, it is very important to, discuss about the personal goals, because as Melanie explained, the most important thing is a person-centered approach, okay? So she'd like to go to the park with her grandchildren, but find walking difficult and tiring. And physical rehabilitation may help. So it is important, the treatment goal is, should coincide with the personal goals, okay? Then the plan of glycemic management may be hemoglobin A1C is elevated, and she has a long life expectancy, so needs glucose lowering is needed clearly, because her hemoglobin A1C is 8.4%. Okay, hypoglycemia must be considered before using insulin, because she had a previous stroke, and it is a risk for those patients to experience hypoglycemia. Hypoglycemia may worsen the stroke. Okay, and also CGM details are needed. And because Susan has some obesity, body mass index 31.2, you need not only glucose management, but also weight management. Weight is elevated and may contribute to walking difficulty, as well as elevated A1C. So this is as a Japanese, algorithms, how to choose that drugs stepwise. Okay. So according to the Japan Diabetes Society guideline, first we choose the drugs whether she or he has obesity or no obesity. And in the Japanese guideline, cutoff point is body mass index 25. So if you do not have obesity, the choices may include DPP-4 inhibitors, metformin, and alpha-glycosid inhibitor glutamate. And if you have obesity, then the choices may include metformin, SGLT2 inhibitors, GLP receptor agonist, and further down to the peptide, okay? And I would like to explain what is the reasons of this order, okay? This order reflects the frequency of usage of a particular each drug in the Japanese, real world hospitals, okay? So together with some, evidence based medicine. So this is a mixture of the frequency of usage as well as some, evidence. So you don't have to use the drugs according to this disorder. This algorithm explicitly says that, okay? Then next we will think about the prioritization. If the patients have CKD or heart failure or CBD, then the priority may include, SGLT2 inhibitors or GLP receptor agonists in each situation. Please go ahead. And in this case, okay, this table is the medications for lowering glucose, summary of characteristics, okay? So I will, the first column is hemoglobin A1C efficiency, and then hyporisk, then weight efficacy, then MACE efficacy. So in the case of Susan, okay, Susanna, because hemoglobin A1C is 8.4%, we have some, drug which is, intermediate to high A1C efficacy. And because she has previous stroke, hypoglycemic risk should be avoided. Then, because Susanna has a body mass index below, over 30, she has an obesity, weight efficacy.
So let's come on to that because we can talk about. So in terms of you started to explore about
So thank you very much.
Yeah, so we're starting to explore about the choices. Do you want to talk a little bit around? You talked about GLP-1s and the risk of stroke.
Okay.
And SGLT2s.
Thank you very much. So because she has a previous stroke, maybe according to the recommendation, GLP receptor agonists and SGLT2 inhibitors may be recommended. Okay, GLP receptor agonists reduce the risk of fatal and non-fatal stroke, which 24% reduction with dulaglutide in the REWIND study, in 32% reduction with semaglutide in SUSTAIN-6 and PIONEER-6 study. So in this case, GLP receptor agonist may be a preferred choice because of the previous evidence to reduce the recurrence of stroke. ACDL2 inhibitors is actually have a only neutral effect on all-cause stroke risk or fatal risk, and so GLP receptor agonist may be a preferred one in this particular case. Okay.
Thank you. So Monica, let's bring you in here. So we've heard Susanna's case. We've heard about the risk factors there. Would you agree in terms of a GLP-1? What would be your thoughts here?
Yeah, definitely I would agree on a GLP-1. I think that would be really a good idea for this kind of patient as presented by Dr. Kadowaki. Definitely not insulin, because she has already some problems with her motion and her walking things, and so I wouldn't put her under risk of hypoglycemia. So I think that's a little bit dangerous, and I'm pretty sure that her HbA1c can be fixed without insulin, so with a GLP-1, which are as good as basal insulin, for example, in HbA1c reduction. So thinking about which kind of GLP-1, to be honest, in her special case, I would probably go for dulaglutide. And the reason why I would go for dulaglutide is, first, we have positive data, as Dr. Kadowaki already shown us, in the reduction of MACE and also in reduction especially on stroke events. So that is an important thing. But the other thing is, I wouldn't put her really on a GLP-1 where he had really a very high efficacy weight loss, because in her case, I would be a little bit afraid that she can get into something like sarcopenia, because she's not moving very much. She has had the stroke. So let it go slowly with the GLP-1 and with the weight reduction. And she needs physical therapists to get muscle strength and not to lose too much muscle mass. So definitely dulaglutide would be my vote.
So I would slightly disagree. So I would probably go. So I think semaglutide has both the stroke evidence and she's got a BMI of 31. And I think the data that we've seen in terms of body composition, both with semaglutide and indeed with tirzepatide, is actually pretty reassuring. But I agree with you about the physical therapy. But I think they're both good choices. But I'm going to...
I would go actually semaglutide or tirzepatide because body mass index 31.2 is much higher about the cutoff point of Japanese guidelines.
Yes.
25, okay.
Yeah, absolutely.
And so, so clearly, obesity-related risks may be reduced by, semaglutide or tirzepatide.
Yeah.
And without hypoglycemia. But as was discussed, clearly, rehabilitation is necessary. And also, in order not to cause sarcopenia, high protein diet may be recommended too.
Perfect.
Yeah.
So let's go to Marcus now. So
yeah, some additional notes on Marcus when he came in the office. He didn't have any real health issues, he thinks, but he was frustrated about his weight gain because it affects his everyday life, especially he likes play football with his friends and his son. So it's gonna be really difficult for him to do this, and he has also some breathing problems with his weight while doing exercise. In terms of the MASH and the chronic kidney disease, where we would be, I would say, bothered as physicians, he doesn't feel this really. He doesn't have symptoms, so he came in and say, I want to lose weight and I'm frustrated about my weight gain. So what would be, if you have these choices here, what would be the most appropriate steps in Marcus' treatment, knowing what his goals are and what his desires are? So there are 6 choices given here. First, intensify glycemic management. He has an HbA1c of 7.5 right now, remember. Second, prevent progression of chronic kidney disease. Third, prevent progression of MASH. Fourth, reduce weight. 5, ask about his goals is always a good idea, I would say. And 6, maintain current regimen, which I don't think is really a good idea in his case. So let's go to the next slide. It's like Melanie Davis showed us, it's a shared decision making. And so we have to listen carefully what the patient's goals are, because if we treat him in a way where he doesn't think he has a problem or he wanna get something fixed, so we are probably not successful. So his goal is Marcus wants to be more physically active, as already mentioned, and he doesn't want to have bariatric surgery. That's not an option for him right now, but he wants to lose weight. Glycemic management, so speaking as a physician, HbA1c is not so bad with 7.5, but remember, he's a young guy, so he has a long life expectancy, so lower would be even better. And remember, like Dr. Davis showed us in the beginning, the metabolic memory. So in his case, at a guy of the age of 43, I think it's worth that we fix his HbA1c as good as we can. So I would definitely see him below 7%. Weight management, remember, that's probably the most important for him. So weight loss has a very high priority, I would say, from a physician point and from the patient point. And by doing this, I'm pretty sure that we can also improve his MASH and CKD, which he has no symptoms right now. And yeah, of course, kidney disease management is also very important for this young man. So he has already a standard of care, I would say. He is already using a SGLT2 and is on an ACE inhibitor, which is recommended by KDIGO. But let's say this recommendation you have seen earlier, even before the KDIGO guideline came out from the EASD and ADA guideline, where Professor Davis was a lead author. And you can see here the box in blue, patients with type 2 diabetes and CKD should be on an ACE inhibitor like Marcus was, and preferably he should get an SGLT2. He was on that already. If that would not be possible, GLP-1 would be a good idea. And then for weight management, also he needs and wants as much weight reduction as he could get. So looking on the anti-diabetic treatment therapies, what we have, and if we see here weight efficacy, GLP-1 receptor agonists have intermediate to very high efficacy, and the dual agonist GLP receptor agonists is the one with the most effective for weight reduction. For chronic kidney disease, of course, SGLT2 have a high priority, but also GLP-1 studies have shown that macroalbuminuria and kidney outcomes can be improved. And that was mainly from cardiovascular outcome disease, but now we have the semaglutide, the first renal outcome trial, the FLOW trial, showing that the GLP-1 semaglutide can also reduce significantly first major kidney disease events, first kidney-specific component events. And as you can see here on the right side, we have also a favorable eGFR slope with semaglutide, so quite similar to what we can see with the SGLT2 inhibitors. Well, with the dual agonist, the only one we have on the market is the tirzepatide right now. With the dual agonist, there is also a kidney outcome study. It's called TREASURE-CKD ongoing. It's also a CV outcome study ongoing. It's called SURPASS CV outcome trial. So far, we have only evidence from retrospective real-world data showing that patients being on tirzepatide have even better reduction in all-cause mortality, MACE endpoints, and also relevant kidney endpoints compared to patients being on GLP-1 receptor agonists. And we have also quite good evidence, I think, in reduction of MASH or resolution of MASH with GLP-1 or dual agonists. So there's one trial, phase 2 trial with tirzepatide in MASH people showing about a 50, depending on the dosage, about a 50% reduction or resolution of MASH without worsening fibrosis. Another dual agonist, which is not on the market yet, it's a glucagon GLP-1 receptor agonist showing basically the same, a 50% reduction without fibrosis worsening. And also semaglutide have shown a reduction in fibrosis and steatosis markers. So, yeah.
So Monica, I think you almost told us what your view was in terms of this young chap, really high BMI of 38. So what would be your preference and what's your rationale for that?
Yeah, I would say if I offer the patient, let's say GLP-1 or a dual agonist, I think they are both good for this patient because he can reduce weight. It's good for his MASH and also good for kidney. But if I would show him, for example, the box of the ADA and EASD guideline, I would say, well, there is something, here, which is quite effective in losing weight, but the most effective one is the dual agonist, but we don't have the real outcome trial right now. He probably will say, well, doctor, let's first go for the most effective one for me. And maybe in a year, the CV outcome trial is there, and then I have lost a lot of weight, and maybe it's as efficient as all the other ones. So he maybe, as I know Marcus, he would probably say, tell me right like this. So I would put him on tirzepatide, I think. In addition, definitely to SGLT2, because SGLT2, it's set because of his chronic kidney disease.
Okay, perfect. So I think we'll move on because of time. So I'm going to come back. I'm going to check in with Susanna, if that's okay. So you've talked about the new medication. She didn't want to go on to insulin because she'd had issues with hypoglycemia. So you're going to go to the GLP-1. So do you want to tell us a little bit about the data about adding a GLP-1 or GIP to metformin?
Okay.
So I think there's been data with both liraglutide in the dual trial added and also from SURPASS-4 with tirzepatide compared to insulin. So we're getting much better improvements in HbA1c. We're getting that with significant improvements in the 24-hour glucose profile, but also advantages with hypoglycemia and weight as well.
Yeah. It is very important that the difference between the insulin and tirzepatide or other GLP-1 receptor agonists. The major difference is the lack of hypoglycemia in tirzepatide or GLP-1 receptor agonist. Also, the lack of weight gain, rather weight loss with GLP-1 receptor agonist or tirzepatide. Although in the case of insulin, you would expect more weight gain. So the independent of glucose lowering effect, which is even higher for tirzepatide or GLP-1 receptor agonist, additional benefits include lack of hypoglycemia and lack of weight gain.
Absolutely. So I think in terms of, and also, Monica, if I can come to you in terms of the ease of administering an injection. So when we put patients on insulin, we have obviously daily injections, but often patients may even need basal-bolus. With the weekly GLP-1s, what instructions do you give to patients?
Well, with the weekly GLP-1s, usually in Germany, our diabetes educator tell them already, we start with a low dosage because the most common side effects are GI side effects. So I would recommend to take smaller meals. Don't eat too fast. Don't eat too fat food, not too spicy, and drink enough water or liquid. So that's very important because it helps to mitigate the side effects in the beginning. And then we start low and try, and depending on the side effects, we titrate up.
Perfect. So let's come back to Susanna. So in terms of the choices, Dr. Kadawaki, do you want to just go through what the choices that you might suggest?
As we have been discussing, Susanna had a previous stroke, okay? And also Susanna has obesity. So insulin is, rather contraindicated, I think. I would never use insulin for this. Dulaglutide, even do not have, weight loss effect. So I would not use dulaglutide because Susanna, as a Japanese guideline, the cutoff point body mass index 25 or more is obesity. 31.2 is a clear obesity and need weight reduction. I would not use dulaglutide. So I would rather, I would use rather semaglutide or tirzepatide. And both can be used. However, if the clinical data showed already that tirzepatide has more glucose lowering effect and weight reducing effect, and because Susanna has a high hemoglobin A1C and high body mass index as a Japanese, I would choose tirzepatide in this particular case.
Yeah, and then we've got semaglutide that's clearly got outcome data in terms of MACE and stroke. So it's, we can debate.
We can weigh among them.
Absolutely. Yeah. So coming back to you, Monica.
Yeah, Marcus, as already mentioned, he wants to lose as much weight as possible. And, he has also CKD. And from the data we know from KDIGO, there is a revised 5-pillar, which showing now as the new pillar is for preventing kidney is now, in addition to lifestyle ACE inhibitor SGLT2 and finerenone, GLP-1 comes in as a new pillar. And if GLP-1 would be added to a patient like Marcus, who is already on SGLT2, what are the data telling us? The data telling us that if dulaglutide is added, we still have a quite good HbA1c and weight change, also with liraglutide, even better with semaglutide, and tirzepatide, as you can see here on the right side, is doing best. And we also have a head-to-head trial. That's the SURPASS-2 trial, comparing tirzepatide with 1 milligram semaglutide, which is in the very dark column or bar seen. And we can see in each case HbA1c reduction and weight reduction is better with tirzepatide compared to 1 milligram semaglutide.
So how do you discuss that then? What, in terms of the sort of decision aid or the decision making, how do you explain those trade-offs to Marcus?
Well, I would talk with him. What's his again? He says weight is my issue, and let's go for the one you told me, which is has the most weight reduction effect. So if you can prescribe me this, I would like to have this one.
And you've already mentioned that you keep the SGLT2 on board.
Definitely,
yeah.
Definitely, he needs it. Yeah. Add in GLP-1, well, that could be an option. If I would add in GLP-1, I would give him definitely semaglutide then. If I'm going because it's his wish, also in its shared decision making for the dual, so it's tirzepatide.
Yeah, so we need to address the clinical inertia and do something, absolutely. So let me just briefly talk about multidisciplinary management, because we know that improves diabetes care. It's really important that we think about the team, the key concepts, the principles of care. But just when we think about diabetes care team, it's gone beyond the doctor and the diabetes nurse now to include the dietitian, podiatrist, psychologist. So it's a very extended team now. Professor Kadawaki, do you want to tell us a little bit about the impact of lifestyle modification?
Yeah,
stroke.
This is a Japanese study telling us that education on lifestyle modification reduced stroke in a randomized control trial in patients with diabetes in Japan. As you can appreciate, right lower panel, the lifestyle modification actually significantly reduced the occurrence of stroke in this particular study, Japan study.
Yeah, and also we talked about exercise and physical rehabilitation. Do you want to just...
Yeah, this graph just simply shows that if a patient do exercise in addition to taking a GLP-1, it's always better in reducing weight, and proportionally they even lose more fat mass in this case.
Okay, thank you. So I think in terms of, Susanna, we've talked about the importance of the multidisciplinary team. So here with the neurologist, we've talked about physical rehabilitation as well, may be really important in her case.
Yeah.
Can we come on to Marcus Marcus as well now, please, in terms of what might be the important factors in Marcus's case?
I would say physical therapist, maybe not, it hasn't to be necessarily a medical physical therapist, because he has no joint pain or any of these orthopedic issues. So maybe a personal trainer is also doing the job, or going into a group and get motivated. I think that's the word for it. Nephrologist, definitely he should see, if he didn't see yet, a nephrologist, just to rule out he has no albuminuria, just to rule out any other kind of kidney diseases, because he is young. And a cardiologist, I would definitely send him to a cardiologist, to be honest, because I think he has a very high risk of having what is called HFpEF, so heart failure with preserved ejection fraction. That can only can be found out by the echocardiogram from a cardiologist. He has a very high risk for it because he has CKD and he is very heavy and has diabetes and hypertension. And if he would have such a condition, then he would be definitely a tirzepatide. Then tirzepatide would be set because tirzepatide in the Summit trial last year is the only compound we know which reduced cardiovascular deaths and also heart failure events. So it has very good data for that. But we don't know yet whether he has it, but I think he has a very high probability to have such a condition.
So let's just talk. So we've talked about obesity, chronic kidney disease. You talked about many of the comorbidities. Obstructive sleep apnea is another one that often is undiagnosed in our patients, type 2. And we've also talked about the multidisciplinary team in terms of, is there anything else, Professor Kadawaki, that you wanted to add to Marcus's case? Anything else we should consider?
I think, of course, because he has a CKD, I think we have been talking about, GLP-1 receptor agonist, tirzepatide, and SGLT2 inhibitors. We also need to, maintain the strict blood pressure control.
Perfect.
Yeah.
And I think he's 43, so he's still pretty young. There's not so many patients under 50 in the trials, and we know that diabetes accelerates aging in these young people, so that's really important as well. So let's just, so I think, Dr. Kadawaki, you enrolled your patient in intensive lifestyle modification, you followed them up, you checked the A1C, kidney function lipids, and the patient was doing well, and you initiated semaglutide in this patient at the starting dose, and they've been doing well.
Yeah. So as we discussed, for Susanna, semaglutide or tirzepatide is a good choice because of the lack of hypoglycemia and also the weight reducing effect. And in addition, because this Susanna has a stroke and some gait disturbances, she wants to improve the gait ability. So she has been on the intensive lifestyle modification class and followed up by 4 months. And in addition, she regularly visit physicians to risk factor controls, including hemoglobin A1C, body weight, and blood pressure and lipids.
Perfect. And so do you want to give us a quick update on Marcus, Monica?
Yeah. Marcus, he went on tirzepatide, starting with the typical dosage of 2.5 milligram. And I think it's very important to give him instructions with this new medication, not only for the injections, also for nutrition, to give him nutritional support. And since it's a chronic disease, I think we have to keep in contact with him. Usually in my country, diabetes nurses are doing it. I think it's very important that they get in phone calls with every week and say how he is doing, what his weight is doing. And I would see this guy probably in 4 weeks, because 4 weeks would be the time when I would up titrate. So I can talk to him how he is doing and so on and so forth. And I can decide whether to up titrate or still waiting on and say I will up titrate a little bit later.
Perfect. Thank you. So we've seen this before, so I'm not going to go through it again, but this really important decision aid, you start with the person, but it's an ongoing cycle really. And I want to give time, because we've got loads of questions, so I want to give some time to questions. So this summarizes what we've gone through today about therapeutic intensification, shared decision making. But I'm going to come to you first, Professor Kellerer, about Marcus. So why why didn't we think of bariatric surgery for Marcus?
You mean why she should have or not have?
Why
Sorry.
didn't? So, what are your thoughts on bariatric surgery instead of? Yeah.
Well, I mean, the first thing is it's shared decision making. So if a patient says, "I don't want to have that," I think that's something we really have to accept. And nowadays, I mean, we have quite good effects with tirzepatide. So we see in weight studies, we see something like up to 25% of weight reduction, which would be quite good for him. That would come to 30 kilograms or so. So why not trying first what he likes? So medical treatment, and give him the chance for also lifestyle modification. Bariatric surgery, we could rediscuss if he is not successful at all, but right now I would say it's not really an option for him because he doesn't want to have it.
Yes, so I think the other point the questioner makes, which is a very valid point, is that they say GLP-1s can be expensive and will incur a long-standing rolling cost as opposed to a one-off cost of bariatric surgery, although I would argue that we do see in many patients or some patients weight regain, and it's not a one-off in terms of some of the ongoing surveillance and management.
Exactly, and resurgeries and so on.
Okay, so Professor Kadawaki, then come to you next. Old patients on GLP-1s. So if you have an older person who loses weight on the GLP-1, but also, what about using GLP-1s in older people?
You talk about the cautions of the GLP-1 receptor use in the aged people.
In old, aged.
Okay.
Yeah.
Okay. I think obese people, if he or she is, older than 75 years old, if she or he is definitely has a definite obesity, I would use GLP-1 receptor agonist or tirzepatide if he really or she needs weight reduction. Okay, because obesity not only causes type 2 diabetes, but other obesity related disease usually exist. So if you have obesity, you may wish to reduce obesity to get hemoglobin A1C lowering, because weight loss actually is accompanied by additional benefits to he or her, in addition to hemoglobin A1C lowering. However, you have to be very careful about the risk of sarcopenia, so that you need to teach he or she that weight train some
it's particularly resistance
physical training,
absolutely,
as well as good nutrition, such as high protein diet.
Perfect. So Monica, if I can come to the last question for you, and a brief answer, please. The use of GLP-1 and tirzepatide during pregnancy and lactation.
Well, right now it's not approved for use in pregnancy and during lactation, so it's a short answer, no.
Yeah, and increasingly when we're using this medicine in early onset type 2 with many young women, we do have to make sure we explain to them that they're much more likely to be more fertile and become pregnant if they lose weight and their A1C improves, but the importance of stopping the medication if they're planning pregnancy. And as you say, no data in pregnancy and limited data with lactation. So thank you very much for your attendance. I hope you enjoy the rest of the IDF in Bangkok, and thank you very much for joining us today. Thank you.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Lilly. To access all materials for this activity, visit peerview.com/MJX860.